Artificial intelligence doctor. User question. What are the age-related physiological changes in the cardiovascular system, and how do they impact the diagnosis and management of heart diseases in the elderly? GPT-01 answer. As individuals age, the cardiovascular system undergoes several physiological changes that can significantly impact the diagnosis and management of heart diseases in the elderly. Understanding these age-related changes is crucial for healthcare providers to tailor appropriate interventions and improve outcomes for older patients. Age-related physiological changes in the cardiovascular system. Structural changes. Left ventricular hypertrophy, LVH aging leads to an increase in the thickness of the left ventricular wall due to prolonged exposure to elevated blood pressure and increased afterload. This hypertrophy can reduce ventricular compliance, affecting diastolic filling. Arterial stiffness. The elasticity of arterial walls decreases with age due to collagen cross-linking and elastin fragmentation. This results in increased arterial stiffness, leading to higher systolic blood pressure and pulse pressure. Atherosclerosis progression. Over time, lipid deposits accumulate within arterial walls, leading to plaque formation and narrowing of arteries, which increases the risk of coronary artery disease. Valve calcification. Calcification of heart valves, particularly the aortic and mitral valves, can cause stenosis or regurgitation, impairing cardiac function. Reduced ventricular compliance. Stiffer ventricular walls make it harder for the heart to fill properly during diastole, potentially leading to diastolic heart failure. Functional changes. Decreased maximum heart rate. The maximal heart rate achievable during exercise declines with age, limiting the heart's ability to increase cardiac output during stress. Reduced cardiac output response. The heart's ability to augment cardiac output in response to increased demand is diminished due to decreased contractility and compliance. Prolonged myocardial contraction and relaxation. The duration of myocardial contraction and relaxation increases, affecting overall cardiac efficiency. Reduced beta-adrenergic responsiveness. Aging reduces the responsiveness of the heart to sympathetic stimulation, affecting heart rate and contractility. Increased systolic blood pressure. Due to arterial stiffness, systolic blood pressure tends to rise with age, contributing to isolated systolic hypertension. Electrical changes. Conduction system fibrosis. Fibrotic changes in the cardiac conduction system increase the risk of arrhythmias such as atrial fibrillation and other conduction blocks. Electrocardiogram, ECG, alterations. Age-related changes can include prolongation of PR, QRS, and QT intervals, making ECG interpretation more complex. Vascular changes. Endothelial dysfunction. The endothelium becomes less effective at mediating vasodilation, contributing to increased vascular resistance and impaired blood flow regulation. Reduced baroreceptor sensitivity. Decreased sensitivity of baroreceptors can lead to orthostatic hypotension, increasing the risk of falls. Impact on diagnosis of heart diseases in the elderly. Atypical presentation. Subtle or nonspecific symptoms. Elderly patients may present with nonspecific symptoms such as fatigue, shortness of breath, dizziness, or confusion instead of classic chest pain during myocardial ischemia. Silent ischemia. Reduced pain perception can lead to asymptomatic myocardial infarctions, delaying diagnosis and treatment. Diagnostic challenges. ECG interpretation. Age-related changes can mimic or mask signs of ischemia or arrhythmias, complicating ECG analysis. Stress testing limitations. Reduced exercise capacity may limit the utility of exercise stress tests. Pharmacological stress tests might be needed but carry additional risks. Comorbidities. The presence of other chronic conditions like diabetes or chronic kidney disease can obscure cardiac symptoms and affect diagnostic test results. Altered laboratory values. Biomarker interpretation. Levels of cardiac biomarkers such as troponins may be elevated due to chronic kidney disease common in the elderly, necessitating careful interpretation. Imaging considerations. Reduced image quality. Age-related changes can affect the quality of imaging studies like echocardiograms, requiring more advanced imaging modalities. Impact on management of heart diseases in the elderly. Pharmacotherapy adjustments. Altered pharmacokinetics and pharmacodynamics. Decreased renal and hepatic function affects drug metabolism and excretion, increasing the risk of toxicity. Polypharmacy risks. Elderly patients often take multiple medications, increasing the risk of drug-drug interactions and adverse effects. Dose modifications, lower starting doses, and slower titration are often necessary to minimize side effects. Invasive procedures and surgical interventions. Increased procedural risks, age-related decline in organ function and comorbidities heighten the risks associated with surgeries and invasive procedures. Preference for minimally invasive techniques. Less invasive options like transcatheter aortic valve replacement, TAVR, may be preferred over open-heart surgery. Non-pharmacological interventions. Tailored rehabilitation programs. Cardiac rehabilitation should be adapted to the patient's physical capabilities, focusing on improving functional capacity without overexertion. Lifestyle modifications, dietary changes, smoking cessation, and moderate physical activity should be encouraged, taking into account the patient's overall health status. Monitoring and follow-up. Regular assessment. Frequent monitoring of blood pressure, electrolytes, renal function, and therapeutic drug levels is essential. Cognitive considerations. Cognitive impairment can affect medication adherence. Involving caregivers and simplifying regimens can improve compliance. Holistic and palliative care. Quality of life focus. Management should balance prolonging life with maintaining or improving quality of life. Advanced care planning. Discussions about patient preferences, goals of care, and end-of-life decisions are important components of management. Conclusion. Age-related physiological changes in the cardiovascular system significantly influence the presentation, diagnosis, and management of heart diseases in the elderly. Healthcare providers must recognize these changes to avoid misdiagnosis and to tailor treatment plans that address the unique needs of older adults. A comprehensive approach that considers the physiological alterations, comorbidities, functional status, and patient preferences is essential for optimizing cardiovascular care in the aging population.